that tendon which was torn. In ILIOPSOAS bursitis, we have to look for the causes. We can have ILIOPSOAS bursitis due to direct trauma with hemorrhage, friction for overuse, inflammatory arthropathy with rheumatoid arthritis. Hip joint effusions may cause fluid in bursa. Have ILIOPSOAS muscle pain or tendonitis may mimic bursitis. There is a case in which there was bursitis, this vessel, and you can see the fluid in the bursa. The wall will be thickened and you can get fluid. Trochanteric bursitis can be due to direct trauma, frictional overload, adverse biochemical factors. Leg length will be different from the contralateral side, running on a banked surface, and for DD you will look for gluteus medius tendonitis, iliotibial band friction syndrome, and tendon TL. There are few cases in which you can see the tendon TS, discontinuity, which is anaerobic. Then coming to hip joint effusions, we can have some effusions, but I didn't have any slide. Then we can have hernias in this type of players. For inguinal hernia, dynamic ultrasound is very important. We use Valsalva or sit-ups or erect. We scan the patient in 3 postures. Dilatation of the inguinal canal with straining is seen. Longitudinal movement down inguinal canal is important, and herniation through posterior wall defect is seen. There is a case in which there was herniation, and this is the right deep inguinal ring and the right deep inguinal ring here. You can see the vessels and herniation. Another case of scrotal herniation, the intestinal loop which is herniated in the scrotum. We can have direct inguinal hernia. We can differentiate between femoral hernia at rest and after giving strain. Sports hernias, instead direct inguinal hernia, we can have conjoined tendon tear, often the cause. Can have chronic pain with exercise, especially kicking, running, sit-ups. And etiology of pain is herniation of peritoneum through defect, enthesopathy, and multiple factors. This is conjoint tendon hernia. You can see the bone in the conjoint tendon which is herniated. There is the right superficial ring at rest, and after Valsalva you can see the herniation here, the difference of the, it seems normal, and at the superficial ring you can see this is the herniated loop. This is Valsalva. Another case at rest and after staining, you can see the herniation. This is the loop which is the part which is herniated. Then we come to sport injuries in knee. The complaints of athletes requiring ultrasound evaluation include articular pain, joint swelling, locking of the knee joint, and internal derangement of the joint. Ultrasound is the best tool for detecting fluid in the knee joint. The demonstration of joint effusion is of paramount importance because the presence of fluid is a sign articular disorder resulting from injury to different components of the knee joint. The first thing in case of injury or trauma is patellar tendon, which should be evaluated. Patellar tendon tear and tendonitis is most common in jumpers, which is called jumper's knee. The most common site for traumatic rupture is at the tendon insertion on the inferior pole of the patella. which may be retracted 3 to 5 centimeter proximal to its position owing to contracture of the quadriceps muscle. We also look for menisci. You can get some weight lifters in which you will have meniscal tears. Here is the lateral meniscus and the medial meniscus. The patient was a weight lifter having pain while walking, and there was a small tear which was confirmed on MRI. Another patient having fluid in the knee joint and there were signs of caseation. We aspirated the fluid and it was confirmed that patient had tuberculous knee. You can even find some small fractures, tendon of the quadriceps femoris, and this is the lower end of femur, and there was a small fracture. There is bone, and you can see a sinus with pus and a part of quadriceps femoris before its insertion. These are medial menisci on both sides, both are normal. Coming to ankle. Ankle tendon sport specific injuries include peroneal tendon. We can have skirts, the runners, dancers, competitive walkers. For flexor hallucis longus, we can have ballet dancers. For Achilles tendon, weekend athletes. There is a case in which there was edema and there was some fluid along with the edema, the right angle and the medial malleolus, and where you can find the tibialis posterior tendon. A case of Achilles tendonitis, you can compare it at longitudinal and transverse sections and compare it with the contralateral sides. And here is tendoachilles, and you can see a small tear which is within the substance. It is intra-substance tear which is involving 1/4 of the tendon. This is partial tear again. You see the discontinuity. You will measure whole of the tendon, you will measure this area and get the percentage. Then is the chronic tendonitis. You will get hyperacute calcified areas with shadows. And in cases of complete rupture, you will get discontinuity and the overlying structures are herniated like skin or subcutaneous area, and this is the same case of complete rupture of Achilles in which there was discontinuity between two parts of the tendon which are retracted to both sides. In tendon pathology, we will look for tendonitis, tenosynovitis, laceration or rupture, tendon repair and tumors. In tenosynovitis, we will look for this area which is anechoic, indicating that there is some fluid between the synovial membrane and the tendon, which can be confirmed longitudinally. It is extensor digitorum longus. You can see the fluid in between the membrane and the tendon. So this anechoic line around the tendon must be evaluated for tenosynovitis. Another case in which you can see fluid with the tendon, you can confirm it by giving some compression at the site. If it is fluid, it will move to the sides according to the compression, the force you are applying. That indicates that there is fluid around it and it is effusion, or it can be severe tenosynovitis. Here it is, again fluid, and we are getting the longitudinal section, and you are getting the fluid. Another case in which there is fluid showing tenosynovitis, tendon in cross sections, can be compared for all fingers. Right and left finger can be compared. This is the normal case, and normally you don't get fluid around the tendon. Tendon laceration and injuries are common, and here you can see the bones and flexor digitorum is absent, whereas here you can see it is torn due to injury. Another case in which there was partial tear due to injury, there was fluid around it, and this is a split within the muscle which indicates that there is partial tear. It can be longitudinal tear or a transverse tear. We can have ligament injuries in the ankles, can be intrinsic in the intercarpal, extrinsic in radiocarpal, dorsal hood of extensor tendons, and sternus liens can be seen. In sternal liens we will have ulnar collateral ligament of the first carpophalangeal joint. For anterior ankle assessment, when there is interior pain in the ankle, especially in the athletes, we look for interior joint space, interior tendons. We look for the tibialis anterior, extensor hallucis longus, extensor digitorum longus. We look for interior ligaments, especially the interior tibiofibular and interior talofibular ligaments. Fluid collections around the ankle are important. The size and amount of fluid in asymptomatic normal volunteers, we have a data. Interior joint space, if it is about 3 mm, it is important. Tibialis posterior tendon at 4 mm, common peroneal tendon 3 mm, and retrocalcaneal bursa 2.5. These are the limits, the lower limits, so we must not get more than this area. These are normal structures which you will look for. This is dorsalis pedis, and then is extensor hallucis longus, the tibialis anterior muscle, extensor digitorum longus, the anterior tibiofibular ligament, and then is the cross section showing all these tendons with vessels. This is tibialis anterior, extensor hallucis longus, and digitorum longus. We can also have tibialis anterior degeneration or tear. Along with that, we can get hematoma formations with chronic tears. This is the long